Hi, this is Mark Purdue, and you're watching EKG Video Tutorial 6.0 on increased chamber size. Following our raised right method of interpretation, we began with rate analysis and then moved on to rhythm. Then we identified QRS frontal axis and then moved on to intervals, PR interval, QRS duration or interval, and then the QT interval. Next, in the I component of raised right is going to be increased chamber size, in which we'll look at atrial enlargement and ventricular hypertrophy. In this photograph from Robbins and Cottrans, you can see in the middle is a normal heart. To the left and right are ventricles that have undergone some type of hypertrophy. Hypertrophy or chamber enlargement occurs in the heart usually as a result of some kind of stimulation. For example, in the case of untreated hypertension or aortic stenosis, the heart has to work against that increased pressure gradient in order to adapt at hypertrophies. On the left, you can see a normal myocardium, and then on the right, you can see hypertrophy, which shows up in significantly increased size of myocytes as well as nuclei. The heart only has a finite number of myocytes. There are no satellite stem cells to renew that tissue, so in the presence of some kind of adverse stimulus, like an increased pressure gradient associated with hypertension or obstructive valve disease, the heart simply has to adapt to overcome. On the left, you can see wall thickening, which is a result of concentric hypertrophy in the case of the myocytes widening out and creates this thick wall. On the right, you can see dilation from eccentric hypertrophy, in which the myocytes actually become longer. These two hypertrophic processes can both occur in the same heart, and ultimately, it doesn't matter what the cause is. If there is increase in mass and volume of the chamber, we will see significant increases in voltage. In left ventricular hypertrophy, for example, you can see the significantly deeper S wave in V1 and then a significantly taller R wave in V6. Let's begin with atrial enlargement. If you look at the graphic to the upper right, we can see that the right atrial and left atrial depolarization have slightly different axes or vectors. As a result of that, V1, which is in the right parasternal region, is going to display those two different polarizations in a biphasic manner, with the initial one being the right atrial and the second one being the left atrial. Now for lead 2, it will display a single unified P wave because overall there is not a significant difference in how the lead 2 perceives those voltages, but it is true that the right atrium depolarizes before the left, so that the first component is right atrial depolarization and the second component is left atrial depolarization. With that in mind, we can look here in V1 and see that in right atrial enlargement, there is a significantly increased amplitude in the atrial portion of the P wave. If we go up to lead 2, also in right atrial enlargement, we can see because there is no biphasic component to this P wave in lead 2, it simply is increased in amplitude. Consequently, we can say that for right atrial enlargement, right is height. Now, if we come down to V1, we can see that the right atrial component is normal, but in the case of left atrial enlargement, we can see that the left atrial component has become deeper and broader. If we move up to lead 2, we can see that this was previously a unified single slope P wave, but now it's taken on this notch. That's because the right atrium depolarizes and is published in this wave here, but because the enlarged left atrium has more mass, more voltage, it takes longer to draw its wave, and so we see this increase in length. Consequently, in left atrial enlargement, it's appropriate to think left is length. So for right atrial enlargement, we're going to look at the P waves in lead 2 and V1. We are going to remember that right is height. That is, for right atrial enlargement, we need to have a P wave that's greater than 2.5 millimeters or small boxes to satisfy that requirement. If we look to V1, we're going to see that the initial right atrial component has become enlarged. That makes perfect sense, and so it's going to be greater than 1 small box in height. If we look to V1, we can see that the early right atrial component of that usually biphasic wave has become bigger than 1 small box. Sometimes right atrial enlargement is referred to as P pulmonale when it's identified on an EKG. This is because of the common causes of right ventricular dysfunction, whether it be long-standing pulmonary arterial hypertension, pulmonary stenosis, or acutely in the case of a pulmonary embolism. Anything that can cause a pressure and volume overload into the right ventricle can easily be transmitted into the right atrium, and so you have the term P pulmonale. Here we can see that in right atrial enlargement, we have the principal right is height. If we look at lead 2, it is definitely well over 2.5 smalls in size, and if we look at V1, we can see that the early right atrial component is the only thing that shows up in this P wave. Here you can see this apical four-chamber view, which displays this massively enlarged right atrium, which is also dilated. Again, this can frequently occur in the setting of pressure and volume overload in the right ventricle that gets transmitted to the right atrium, or in some kind of congenital heart disease. For left atrial enlargement, it's helpful to remember that left is length. If we look at lead 2, we can see that because that increased left atrium has become bigger in size and therefore will take longer to depolarize and therefore longer to draw its wave, it's created not a single unified P wave, but this humped creature. You can see that this second component is consequently going to increase the width of the P wave to greater than 3 small boxes. Then if we go out and look at V1, we can see that the second left atrial component of that P wave is significantly increased in size as well, to the tune of greater than 1 small box. Because left atrial enlargement is frequently associated with mitral disease, it is sometimes referred to as P mitral. Here we have a 12-lead EKG of left atrial enlargement, and if we remember that left is length, we can see that there is a prolongation of the width of the P wave here. They are quite prominent. Here, when we look at V1, we can see that there is no longer a biphasic component, but just a negatively deflected P wave. That is a result of significant left atrial enlargement. That negative component's kind of taken over, and it is greater than 1 small box. Here we have left atrial enlargement in which the left is length principle becomes a little more evident. If we look right here, we can see this very broad, greater than 3 small boxes P wave with its significant notching, and then there is a return to the biphasic component in V1. Left atrial enlargement frequently comes in association with mitral valve disease, whether it be mitral valve stenosis, regurgitation, or both. We will now turn our attention to left ventricular hypertrophy. In left ventricular hypertrophy, we've discussed previously how common disease processes like uncontrolled hypertension and obstructive aortic stenosis can cause a pressure gradient against which the left ventricle has to work, and as a result, it adapts to overcome that through the process of hypertrophy. We've also mentioned how left ventricular hypertrophy can come in association with the various cardiomyopathies, and how this increase in mass results in an increase in voltage. We can see those principles demonstrated right here, where the negative component has increased in depth in V1, and then the positive component in V6 has increased in magnitude. The specific criteria for left ventricular hypertrophy are going to be an S wave in V1, that's the negatively deflected component, plus the amplitude measured in millimeters in the R wave of V6, that's the positively deflected component, are going to register as greater than 35 millimeters. Some have suggested that an R wave in AVL that is greater than 11 millimeters is another criteria for LVH, and some have suggested that it can be a lone criteria for LVH. Importantly, it is very common for T-wave inversions to occur in the opposite direction of the overall amplitude of the QRS complexes in LVH. Let's have a look at this 12-lead EKG. Here we have a QRS complex that falls on the heavy hatch mark, so we're going to count our heart rate: 300, 150, 100, 75, 60. The rate is 60. We are now going to look for rhythm. We can see that there are obvious P waves in lead 2. Now we're going to move on to rhythm. We can see in lead 2 that there are obvious upright P waves, which are uniform in size, shape, and appearance, and then upside down P waves in AVR. We have sinus bradycardia at a rate of 60, or simply sinus rhythm. Now we move on to axis. Here we can see in lead 1 that the overall net vector is upward, and in AVF the overall net vector is downward. We have the possibility of a left axis deviation, and so we look to lead 2 as a tiebreaker, and it is overall net negative. We definitely have a left axis deviation. Now you might recall that anytime we have a left axis deviation, we need to consider the prospect of some kind of a fascicular block. In the case of left axis deviation, left anterior fascicular block, and we do indeed have one. Here we can see a small Q and a large R in 1 and AVL, and then we see a small R and a large S wave in 2, 3, and AVL. That, in combination with the fact that the QRS complexes are less than 3 small boxes, we do have left anterior fascicular block. Moving on to intervals. For PR interval, we can see here in this complex that the P wave, the PR segment, and then the initiation of the QRS complex all fit within one of these intermediate boxes. So the PR interval is less than 0.20 seconds or 5 small boxes. Now I can just eyeball this QRS complex and tell that it's less than 3 smalls, but it is slightly prolonged, and if we measure that out, it might be right at somewhere around 3 small boxes, but not greater. The QT interval can be easily eyeballed, and we could see if we drew a perpendicular line bisecting these two fields that it would fall right here, not on the T wave. Our QT interval appears to be normal. We have completed our interval, so we move on to increased chamber size. If we look at lead 2, we do not see any right as height or left as length criteria, nor do we see those in V1. We also know that we have a left axis deviation as a result of our left anterior fascicular block, and so that excludes right ventricular hypertrophy because you have to have a right axis deviation. If, however, we look at the RS in V1, the S wave is 5, 10, 15, 20 millimeters over here, and then the R wave over here is 5, 10, 15, almost 20 over here. That's well over 35 millimeters. We do indeed have left ventricular hypertrophy by voltage criteria. Let's have a look at this 12 lead EKG, and we're going to look directly at indicators of increased chamber size. Now, if we look at lead, a little bit of bumpiness here, and this P wave looks a little bit prolonged, so we're going to say possible left atrial enlargement. Now we're going to move on to our ventricular indicators of hypertrophy. If we look at the negatively deflected component, or the S wave in V1, and then we look over here in V6, you can see that these amplitudes are easily going to match up to be greater than 35 millimeters. In fact, this one is so deeply negative that it's actually interposing on the lead below it. Here we have definite increased amplitude in the QRS complexes. We have left ventricular hypertrophy, and then also we have this T wave inversion, which is quite prominent and associated with downsloping ST segments here. So this EKG is going to make it very difficult to assess for ST T wave abnormalities in the setting of chest pain. Again, here in this 12 lead EKG, we can look at V1 and see the negatively deflected component, and then in V6, the positively deflected component easily register 5, 10, 15, 20, 25, 35, 40, 55, 60 millimeters of increased amplitude. So voltage criteria are definitely satisfied. If we look over here, we can see definite downsloping ST segments and T wave inversions. This, of course, is left ventricular hypertrophy with T wave inversion. Now we move on to right ventricular hypertrophy. Let's move on to right ventricular hypertrophy. Now we know at baseline that the right ventricle has a smaller mass than the left ventricle, and as a result of that, the increased voltage requirements are going to be lower. Here we can see potential causes for right ventricular hypertrophy are going to be those things that we've mentioned in association with right atrial enlargement, things like pulmonary hypertension and cor pulmonale, acutely pulmonary embolism, and that's something to keep in mind. Anytime you have right heart overload, you should consider that, particularly in the setting of a patient with shortness of breath and new onset hypoxemia. In terms of congenital heart disease, right ventricular hypertrophy is associated with tetralogy of flow as well as pulmonary stenosis and arrhythmogenic right ventricular cardiomyopathy. To diagnose right ventricular hypertrophy, we need to see enough hypertrophy or increase in mass of the right ventricle that it drags the electrical axis from the leftward position more rightward. Consequently, our first criteria of right ventricular hypertrophy is going to be right axis deviation. Now, if we were to look here, we can see that there is a significant increase in this rightward deflection, or the positive component of the R wave, so that the next criteria is going to be an R wave in V1 plus an S wave in V5 or V6 that is greater than 10 millimeters. Actually, here the R wave achieves it very easily on its own. Another criteria that has been proposed is the R wave to S wave ratio in V1 is greater than 1. That quite simply means that the R wave is just bigger than the S wave. Now, also in right ventricular hypertrophy, you are going to have these T wave inversions, so that's something to keep in mind in terms of your ST and T wave analysis. In this particular EKG, we can see in V1 that there is well more than 10 millimeters of amplitude in the R wave, and over here more than 10 millimeters of amplitude in the negative amplitude in the S wave, so we easily satisfy voltage criteria. If we look for axis deviation, we can look at 1 and see that it is all the way net negative, and if we look at AVF, we can see that it is net positive. So we have right axis deviation, we have prominent R wave amplitude and prominent S wave amplitude in V1 and V6 respectively that outstrip the requirement for 10 millimeters, we have right ventricular hypertrophy. Let's have a look at this 12-lead EKG. We're going to start with rate. Here we can see a QRS complex that's on a hatch mark, and we can see 300, 150, 100. The rate here is about 120. We definitely have a tachycardia. Let's look at lead 2, and we can see that there are upright P waves that are uniform in size, shape, and appearance. One P wave for every QRS complex. There appears to be a fixed PR interval that is not prolonged. If we look up here in AVR, we can see inverted P waves in AVR. We have sinus tachycardia. Next is going to be axis. If we look at lead 1, we can see it's negatively deflected and AVF is positively deflected. The upward thumb defines the axis, and so we have a right axis deviation. Next is going to be interval. Next is going to be the PR interval. We can see here that the P wave, the PR segment, and the initiation of the QRS complex all fit well with one of the intermediate boxes, and so it's going to appear normal. QRS complex, by eyeballing, it appears to be normal also, and the QT interval is a little more ambiguous in previous cases, but I think it's going to be normal with the perpendicular line coming right here. The other eye in our raised right mnemonic is going to be increased chamber size, where we're going to look at lead 2 and then V1 for first findings of increased atrial enlargement. Now, if we look at this P wave in lead 2, it is slightly increased in amplitude, and it also looks a little bit large. And if we look over here, we have a negatively deflected P wave in V1. This is kind of a mixed signal. So what I'm just going to say here is that there is possible atrial enlargement, and it doesn't neatly fit into either one of those patterns. Next, we're going to move on to left ventricular hypertrophy, and we do not see voltage criteria in V1 or in V6 to satisfy that requirement. We do, however, have voltage criteria in V1 positively deflected and V6 negatively deflected that will satisfy the criteria of greater than 10. We do have right axis deviation, and then also we have significant T wave inversion throughout these anterior and mid leads. So to summarize, in atrial enlargement, right is height. For the right atrium to be significantly enlarged, we have to see a P wave greater than 2.5 millimeters, and then the initial right atrial phase of V1 to be greater than one small box. In left is length. For left atrial enlargement, we look at lead 2, and if we can see that lead 2's P wave is greater than 3 small boxes, we can say that there is probably left atrial enlargement. This would be further confirmed in V1 if the second left atrial phase of the biphasic P wave in V1 wider and deeper than one small box. In the case of hypertrophy, we can remember that left ventricular hypertrophy, as shown here, is established when the S wave, the negatively deflected wave in V1, plus the R wave, positively deflected in V5 or V6, measures greater than 35 millimeters. Some have proposed an R wave in AVL being greater than 11 millimeters as a sole criteria for left ventricular hypertrophy. Also, we should be aware that there are T wave inversions and ST segment abnormalities associated with LVH. For RVH, we must have a right axis deviation to demonstrate that there has been sufficient right ventricular hypertrophy to alter the axis rightward. Also, we'll be looking for the R wave in V1 plus the negatively deflected S wave in V5 or V6 to be greater than only 10 millimeters, as the right ventricle has a much smaller size from its baseline and so requires less change. Also, the R to S ratio in V1 has also been proposed, which is simply a very large R wave in V1. Also, we can see significant T wave inversions in the mid and anterior leads. Next up is 7.0, ST segment and T wave abnormalities, as well as other indicators of ischemia and infarction.